questions. Our next presenter is Hasib Sidiqui. Hasib is the founding member of the AAN. He is a hematologist and the head of amyloidosis service at Fiona Stanley Hospital in Perth. Hasib spent 2 years at the Mayo Clinic in Rochester in the USA under Dr. Maury Gertz, who is the world leading specialist in the field of amyloidosis. And he returned to Australia in 2019, settled in Perth. And his clinical interests are in optimizing treatment outcomes for patients with myeloma and amyloidosis through the expanded clinical trial participation, especially focusing on immunotherapy. So please help me welcome Hasib.
Thank you so much for that introduction, Olga, and thank you for asking me to present. First of all, thank you, Pat, for your labor of love over the last, 3 or 4 decades, for everything that you've done for the AAN, and hopefully, to a certain degree, you are seeing some of those fruits of that labor in the way that the AAN has progressed and grown. A lot has happened over the time that even I've just been involved with the AAN. So thank you, Pat. I was going to just do a bit of an introductory talk on amyloidosis. And I'll try and keep it reasonably short, but happy to sort of take questions at the end. And thought I'd kind of set the scene. I know there are some of you that are very well versed on amyloidosis. There may be others who are only very new to it and are just starting to learn. So bear with me if some of this information is information that you've heard many times before. Now I'm going to just click on slideshow, and I'm hoping that it still looks okay and works okay.
Yep, it looks great.
Fantastic. Okay, so the overview of the talk today, we're going to talk about what is amyloidosis, the different types, how it affects patients, and then just touch base on some of the challenges that are involved in diagnosis. So what is amyloidosis? Well, I often describe amyloidosis as an umbrella term that really describes a host of disorders, all that share a same pathway to a problem. And that pathway is that you have a protein in the blood that misfolds or goes wonky. And then these misfolded protein components form, aggregate together to form these fibrils. And then these fibrils that aggregate eventually deposit in organs or tissues, causing organ dysfunction or problems with those organs. So this is what amyloidosis or amyloid looks like under a microscope. It's like this amorphous kind of pinkish substance. And then we have a specific stain that we use called the Congo red stain that highlights this amyloid for us. We look at it under polarized light, and it gives off this pretty picture with this apple green birefringence. And that's the gold standard for diagnosing amyloidosis. You need a tissue sample, wherever that may be in the body, that has amyloid in it that we identify using this Congo red stain. We know it's a rare disease. But I would say that the incidence of amyloidosis is growing, and we'll touch a little bit on why that may be, particularly with the rise in the identification of transthyretin amyloidosis. But particularly in the AL setting, we probably would see 10 to 20 patients per year in Perth. And again, that number is the overall number of amyloidosis diagnoses in Perth is going to increase, I think, over the next 5 to 10 years. And that's primarily going to be driven by transthyretin amyloidosis as opposed to light chain amyloidosis. And I'll sort of have a bit of a discussion about why that is. So amyloidosis can be acquired or hereditary. So there are hereditary forms of amyloidosis where there's a genetic mutation that's passed on down the family that leads to amyloidosis. Otherwise, the vast majority of amyloidosis is an acquired condition. It is not hereditary, not something that you've got because of a mutation passed down from parents, and not something that you're going to pass on to your children or offspring. It can be systemic or localized. Systemic meaning that it involves multiple different organs in the body, localized usually in one spot, and we'll briefly talk about that as well. So what are the different types of amyloidosis? Well, the type of amyloidosis really depends on the protein that's gone wrong in the system that is forming amyloid. There are over 30 different types of amyloidosis, and all of that is contingent upon what protein is it that has gone wonky or is misfolding and then forming these fibrils and aggregates and depositing in the organs. By far, the most common ones that we deal with are immunoglobulin light chain amyloidosis, or AL amyloid, and transthyretin, or ATTR amyloid. So you can see the nomenclature of how we name this. A stands for amyloid, and then the next set of letters refers to the protein subtype. So in light chain, it's AL. In transthyretin, it's ATTR. And as I mentioned, the most common ones that we deal with as hematologists, the most common ones that we deal with are light chain amyloidosis, or AL amyloidosis. There is a AA amyloidosis, which traditionally has been associated with chronic inflammatory conditions. So this was far more common in decades gone by, when people had inflammatory conditions like rheumatoid arthritis, lupus, that we didn't have great treatments for. So there was chronic inflammation in the body. There was this serum amyloid A protein that constantly was elevated, and this would form amyloid and typically used to affect the kidneys. We're seeing far less of that now that we've got really fantastic treatments for some of these chronic inflammatory conditions. In terms of the hereditary or familial type of amyloidosis, by far the most common here that we are aware of and deal with is the hereditary form of transthyretin amyloidosis. There are a couple of other far less common rare forms of hereditary amyloidosis as well. And the type of amyloidosis that I think we're going to increasingly see, over the coming years, is this wild type transthyretin amyloidosis. So this is an acquired condition. It's not because of a genetic mutation, but it's because over time, this transthyretin protein in the system misfolds, becomes unstable, misfolds, and forms amyloid. And then localized amyloidosis is a form of amyloid that really is identified in specific locations in the body without causing systemic organ dysfunction. So this is often found in one spot. The most common areas that we find this are in the urinary tract, so often in the bladder or the ureter. Sometimes someone has a cystoscopy and the urologist notices something there. They take a biopsy and it shows amyloid. We also can see it in the nasopharyngeal tract or the gastrointestinal tract. But the important thing is that when we investigate these patients, they don't have any other features of amyloidosis affecting other critical organs like the heart, the kidneys, the nerves, the liver, etc. And for the most part, these patients who are diagnosed with localized amyloidosis don't actually require any specific treatment. If, for example, the amyloid in the bladder or the ureter is causing a blockage, the urologist will just resect it away. There's a good study from the Mayo Clinic that looked at people who were diagnosed with this type of condition over a 10 to 15 year period. None of them developed the, systemic disease where the heart started getting affected or the kidneys started getting affected. We've kind of talked a little bit about light chain amyloidosis, but just to go into a little bit more detail, As I mentioned, this is the one that hematologists deal with the most, and this starts in the bone marrow. So what you have are bad plasma cells. Plasma cells are part of our immune system. They live in our bone marrow, and they produce immunoglobulin proteins that help us fight infections. Something goes wrong in one of these cells, and they start to, A, increase in number in the bone marrow, but B, produce this light chain protein that then misfolds and forms these amyloid fibrils, and then it deposits in organs, causing organ dysfunction. By far the most common organs that are affected here are the heart and the kidneys, although it is a multi-organ disease. It can affect the liver, the nerves, the gastrointestinal tract, soft tissues. So it really is a multi-organ system disorder, but the problem originates in the bone marrow with bad plasma cells that produce the bad protein, and that's what leads to the organ dysfunction. The hereditary transthyretin amyloidosis occurs because of a mutation in the transthyretin gene. Transthyretin is a protein that's produced by the liver. This mutation makes the transthyretin protein unstable. Once it becomes unstable, it undergoes that process of misfolding, forming fibrils, and then depositing in organs. Interestingly, the different genetic mutations can lead to different syndromes or symptoms. The two most common ways that this manifests, depending on the mutation that you have, are either involvement of the heart or involvement of the nerves. Now, there's sometimes a little bit of overlap. There are some mutations that cause some heart problems as well as some nerve problems, but they tend to depend on the mutation. And really, once you've actually identified that someone has this type of amyloid in the heart or in the nerves, the important thing to do is a genetic test to identify the mutation. This, of course, has a number of other implications for family members of patients who are diagnosed. But the key to diagnosing this hereditary form ends in a genetic test confirming the mutation. What I mentioned before about wild-type transthyretin amyloidosis, I think over the next decade, this is going to be the most common type of amyloidosis that is diagnosed. This is not because of a hereditary mutation, but because for some reason or another, the transthyretin protein, as we get older, becomes unstable in the system. It tends to be more common in men than it is in women, and it tends to have, again, a very sort of pathognomonic or a very typical presentation in terms of the symptoms that it causes, because it tends to primarily affect the heart as the primary critical organ. So people present with symptoms of heart failure, but there are other clues. So the other area that it can deposit in is in the wrist, causing carpal tunnel. Almost all patients who are diagnosed with this condition will have had carpal tunnel issues in the years preceding being diagnosed with transthyretin amyloidosis. It can also cause issues in the spinal canal and back pain for patients. Biceps tendon rupture is another common sort of symptom that people who are diagnosed with this will give a history of. They go, oh yes, a year or 2 years ago, I ruptured my biceps tendon. And again, it's because of this amyloid causing issues with those tendons. We've talked about localized amyloidosis. As I mentioned, this is often incidentally found during a procedure for another reason. So whether it's a cystoscopy and then you find it in the bladder, or a gastroscopy and you find it in the gastrointestinal tract. But this is when you find a spot of amyloid in these areas. It's usually caused by something that's causing a bit of inflammation in that specific location. But anyone who's diagnosed, and I get a number of these referrals over the course of the year, I will review them, and then I try and look to see if there's any evidence that there's amyloid anywhere else, in particular those critical organs that we mentioned, the heart, the kidneys, and so on. But once I've ruled that out, then I know this is localized. If it's already been resected, great. If it's not causing any symptoms, well, we don't really need to do anything about it. I do monitor patients sort of once a year, maybe once every couple of years, just to make sure that there's no evidence of progression. And this can either be done through our clinics or even just through your local GP. So what kind of tests do we do for patients with amyloidosis? Many of you are very familiar with a lot of these tests, but we will do a number of blood tests and urine tests in terms of specific types of amyloidosis. For AL amyloidosis, the important tests are looking for those paraproteins or light chains that are becoming amyloid. But we do tests that look at all your organ function. So we'll do the full blood count. We do kidney function, liver function, to ensure that we get a good assessment of all of the organs and ensure that we are not missing any organ involvement. The genetic testing in terms of blood tests, I mentioned before, it's really when we suspect you've got a hereditary form of transthyretin amyloidosis. In terms of assessing the heart, doing an electrocardiogram or an echocardiogram is very common. Occasionally, we have to do an MRI scan, and increasingly, we are using bone scans. So bone scans were very common for things like prostate cancer and other bone diseases. But what we found is that in this transthyretin type of amyloidosis that affects the heart, the bone scan is a very good test to try and make the diagnosis. So it is universally positive in people with transthyretin amyloidosis affecting the heart. And so it's a very good way of picking up heart involvement with transthyretin amyloidosis. But as I said, one of the gold standard diagnosis in general for amyloidosis is identifying a tissue sample where we've got amyloid. And so it is very common for us to look at biopsying tissue samples of organs that might be affected. For light chain amyloidosis, what is commonly done is the bone marrow biopsy, because this allows us to actually look at the marrow and look for those bad plasma cells that are producing the light chains. And we also do a fat aspirate, which is just a biopsy of the subcutaneous abdominal fat. And often we can find amyloid in one of these two locations. Occasionally, if we aren't able to find amyloid there, then we have to chase things further. So, there are patients who have had to have kidney biopsies or heart biopsies or nerve biopsies to confirm the diagnosis of amyloidosis. What about staging? Well, staging really is designed to help us determine the extent to which your organs are involved. For the most part, these will generally involve blood tests or urine tests in the case of kidney involvement. And really, the most common sort of staging system that we use for light chain amyloidosis is the Mayo staging system, which is dependent on how the extent to which the heart is involved. And that staging system relies on two blood tests that assess cardiac function or cardiac stress more accurately. That's the NT-proBNP and the troponin. But, again, like I said, there'll be a number of blood tests we do to try and determine the extent of involvement of the various organs. But in terms of staging, really, the two kind of organs that we look at to try and stage is the heart and the kidneys. These are the most critical ones that are often involved. So what about treatment? Well, treatment really is dependent on the type of amyloidosis that we're dealing with. And treatment can be significantly different for the different types of amyloidosis, which is why it's very important to be clear about whether we are, for example, treating light chain amyloidosis that's affecting the heart or transthyretin amyloidosis that's affecting the heart. If you've got light chain amyloidosis, that's because of the bad plasma cells in the bone marrow. Well, the standard treatment for that is giving you chemotherapy medications to kill off those bad plasma cells in the bone marrow. Whereas if you have transthyretin amyloidosis, well, we now have a number of drugs that have been recently approved and are now on the PBS to try and stabilize that transthyretin protein. So two vastly different treatments. So you certainly don't want to give someone who has transthyretin amyloidosis chemotherapy and vice versa. So it really depends on the type of amyloidosis you have. How does it affect your body? Well, as I hope I've kind of explained over the course of the last 15 minutes, amyloidosis is really a multi-system disorder. It can affect, really any organ in the body, but the most common ones and the ones that obviously we get, most concerned about are the critical organs, the heart, the kidneys. But as I'm sure many of you are aware, involvement of the nerves is very common, particularly with hereditary forms of transthyretin amyloidosis. Involvement of the gastrointestinal tract, which causes symptoms like nausea, vomiting, loss of appetite, all of those kinds of, difficult to manage day-to-day symptoms can be affected. And then, it can affect your soft tissues. We've talked about carpal tunnel syndrome, particularly in transthyretin amyloidosis. In some patients, it can affect the eyes, and that can manifest in a variety of different symptoms. So it's truly a multi-system disorder. And I think that's part of, why we need a multidisciplinary team. You'll often, I'm sure, again, many of you are involved with a number of different physicians that help manage your amyloidosis. So you'll be seeing a hematologist, a cardiologist, a nephrologist, a kidney specialist. Then we've got our allied health team that are very important, like the physiotherapists and the dietitians and so on. So it really, requires a concerted effort from the whole team to try and really optimize how we treat this. And just to finish up before we take questions, one of the big things is challenges in diagnosis. And I would say almost, every few months I will end up seeing a patient who is diagnosed with light chain amyloidosis, and the story is always the same. They have had symptoms for maybe 18 to 24 months. They've seen a number of different physicians and doctors and had so many tests along the way, and no one, could give them an answer for a long time. And then eventually things have progressed to a point where finally, a diagnosis of amyloidosis has been made. And I think, obviously one of the reasons for that is it's a rare disease. There are a lot of physicians out there that have never heard of amyloidosis, let alone, understanding the different subtypes and how to diagnose it and so on. The symptoms with which, patients present can be non-specific, can be very varied, and can mimic other sort of common diseases. And so, again, such a rare disease as amyloidosis isn't often at the, top of people's minds. And then, of course, once people think of amyloidosis, the next step is trying to identify what type of amyloidosis you have. We don't have one test that can just, confirm what type of amyloidosis you have, a simple blood test or anything like that. Often it's a combination of using the blood tests, the tissue biopsy, the scans of the heart, and trying to put all of those things together, and ultimately, sometimes requiring specialized subtyping tests or genetic tests to be able to come to an answer. So that's all I had to present, but I'm happy to take any questions or any comments.
Thank you so much, Hasib. That was a fantastic introduction to a very complex condition. And I just love how you laid out in such simple terms. I think, sometimes it's hard to get your head around how all these different symptoms can affect the body and how we go about diagnosing this condition. If you don't need to leave immediately, do you mind if we hold questions until the end, or do you need to sign off?
I'm really sorry, but I do have to sign off. Sorry, Olga.
Okay, that's fine. That's all right. So let's take a few questions for Hasib. And I'm very happy for you to just raise your hand or speak up rather than leaving it in the chat.
Hasib, it's Kath.
Okay.
Can you just tell us about if there are any new therapies developed for the AL especially, which confirms me. I know that we have daratumumab and things like that, but there are some other immunomodulatory therapies that might come down the track. Is there any way you can just chat very briefly about that?
Of course. So look, light chain or AL amyloidosis, traditionally we've treated by trying to take drugs from myeloma, which is a cancer of the plasma cells, and use it in AL amyloidosis. We've had daratumumab approved for a couple of years now as frontline therapy. But there are a number of other novel treatments that are being looked at in this space. First of all, in the myeloma space, we've had a flurry of new immunotherapies. So drugs that harness your immune system to try and treat these plasma cells, these bad plasma cells, and they're highly effective in that setting. They have unique side effects, which may be even of more importance in people with light chain amyloidosis, where your kidneys or your heart might be affected by the amyloidosis. But I can tell you that we are starting to see reports of those agents being used in amyloidosis with some, very encouraging results. So there is a clinical trial with belantamab, a drug called belantamab, which is going to run in AL amyloidosis, which will be very interesting. There was just a publication of a small case series of patients treated with a drug called elranatamab, which is a immunotherapy, a bispecific T-cell engaging. It uses your immune cells to try and kill off those plasma cells. So that drug has just recently been approved for myeloma in Australia. And there was just a publication in a case series of patients with light chain amyloidosis where that drug was very effective. So I'm hopeful that things will filter into the light chain amyloidosis space as we get, some of these fantastic treatments being used increasingly in multiple myeloma. And I think really that's where I see the next sort of big group of treatments coming for AL. Some of you might know we have tried to use medications that will actually get rid of the amyloid from organs like the heart and the kidneys. Unfortunately, the 2 or 3 drugs that have been trialed in that setting thus far have not really come up with impressive results, and really that remains kind of the holy grail of like amyloidosis treatment. If there was some way we could get amyloid that's already in an organ out, that would be fantastic. Thus far, we haven't achieved that with a medication. Sorry.
Thank you so much. Thank you so much, Hasib. I didn't realize I was on mute. Thank you. We will let you go. Let me thank you for your participation today, for taking the time out of your busy schedule. And it's really important for us to bring more education into this forum. So really appreciate you coming to talk to us today. Thank you, Hasib.
Not a problem. Thanks. And I'm happy to share the slides. I think there was a message in the text saying if anyone wants the slides or a PDF form, we can sort that out later.
And I think this meeting is being recorded as well, if you'd like to go over this. Yep.